Hello, greetings, everyone. Thank you. Thank you for joining us for the Psychologist as Educators for the Primary Care Workforce, hosted by the Society for Health Psychology's Integrated Primary Care Interest Group and co-sponsored by the Society for Clinical Psychology, APA Division 12. I'm Chase Gross. I'm the chair of the Integrated Primary Care Interest Group. And before we begin, I just have a few items to share with y'all. So first, this and all of the Society for Health Psychology's virtual presentations are offered as a free benefit of membership in the Society for Health Psychology. So please invite your colleagues and your students to join to ensure unlimited access to future presentations and other society benefits. Um, Also want you to know that this webinar is eligible for one continuing education credit. So under the Society of Clinical Psychology, Division 12 sponsorship, and a CE evaluation will be sent to you via email for all those who attend the full presentation. So, and that will come shortly after the webinar. Um, We'll leave the evaluation portal up for 1 week. That's until 5 p.m. Eastern on Wednesday, October 16th, 2024. And the CE certificates will be sent via email within approximately 5 to 10 business days after the evaluation period closes. And we'll send those will be sent to the email in which you've enrolled in this session. All participants are invited to also submit feedback via the evaluation, even if you're not seeking credit. All right, so let's get to it. I'm honored to introduce our speaker. So, Dr. Meredith Williamson is a licensed psychologist and board certified clinical health psychologist. She is the director of integrated behavioral health and a clinical associate professor for the Department of Primary Care and Rural Medicine within the Texas A&M College of Medicine. She is also the associate program director for the Texas A&M Family Medicine Residency Program. Dr. Williamson has developed innovative integrated behavioral health curriculums and interdisciplinary service delivery. In 2024, the Association of American Medical Colleges awarded Dr. Williamson and her team the Mental and Behavioral Health Training Award for the innovations in integrated primary health education. So she also serves on Division 38 Integrated Primary Care Special Interest Group and the ABPP Board for Clinical Health Psychology. So Dr. Williamson has also had numerous publications and national presentations, and we welcome her here today to give us this presentation. So please, Dr. take it away.
All right, sounds good. Thank you, Chase. And welcome, everyone. If you're like me, you're running around from clinic this morning, so hopefully you can take a breath and get some lunch for this presentation. But today we're going to really be talking about what the role of a psychologist can be as an educator, both for other psychology learners or other psychologists, but also for the broader primary care workforce. In my training, I did not get training necessarily on curriculum development and things like that in my graduate education. And so this has been a lifelong professional learning journey post graduation from graduate school. And I'm happy to share with you all today. So I hope by the end of this presentation, for those of you that may not be as familiar with integrated primary care, you have some idea of what the role of a psychologist is on that team, and also who the team members may be on the team, that you understand a little bit more about competency-based education and the role in primary care for this model. And then also just understanding the unique aspects of being a behavioral health provider within primary care settings. So to start with, I just wanted to put primary care teams within the context of a much broader socioecological model. And so when we think about primary care and our role as a psychologist, it can go as broad as policy. We have regular meetings with our Congress representatives for A&M to try to influence policy on the broader national level, on our state level. It can be within the community, being on different boards to improve things like insurance or care team coordination. But then it's often our daily lives occur on that organizational level. And so we're going to really focus on the care team itself within the specific healthcare delivery system. And then also as you as an individual, as an educator, and then also those that you may be training as learners in that space. So for any of you that may not be familiar with primary care teams, I just want to make sure we're all starting on the same page. So ideally, the patient and family are in the middle of that care team. They are part of the ones making decisions about care within primary care. But the primary team usually involves some kind of primary care clinician, whether that's a physician, a nurse practitioner, PA, and your medical assistant or nursing team, along with other office staff, such as front desk staff, your care coordinators, referral coordinators, and then you have a broader network. And so, as a psychologist, we often fit within that broader network, especially if you're working in integrated care as a behavioral health consultant or other behavioral health specialist. Often social work is involved, pharmacy may be involved. If you're at a federally qualified health center, you may have dentistry on site. And then you have multiple different kind of care coordination team members. That can be a care manager, a community health worker, individuals working with the schools. And then you see the orange, which is on the outside of that circle. And those are the community supports that are still part of that care team, but may not be housed within the clinic. And this could be school-based supports, social supports such as things like food banks and transportation services, hospice, home health, and any other health behavior support that may be involved in the community. And so, as a psychologist, we actually often find ourselves, if you're working in integrated primary care, touching a lot of these different care teams and being asked to provide education, both to those that are already licensed and part of this care team. And then, if you work in an academic setting like I do, there are millions of learners always going in and out of your clinical space. And so, you're called upon to educate them as well. And I just wanted to make sure we also are all aware of some of the evidence-based models for this care integration as psychologist. Since I don't know who all is working in integrated primary care and those that may be broader health psychologists. So really quickly, there are multiple models for integrated care within primary care. The first one that we'll talk about today is the primary care behavioral health model. And the idea of this model is that the primary care provider is the main consultant on the team, and they can reach out to a behavioral health consultant that may be a psychologist or other behavioral health provider who is on call to come in either before, during, or after the visit to intercept that patient based on the needs of the provider and then also the presenting concern of the patient. That behavioral health consultant or psychologist on the team can then pick that patient up and cover them or carry them for as long as they need to in a continuity of care model, just like the primary care provider. Often this may be in brief, kind of problem focused or solution focused spurts, but it really can be across the lifespan. In addition to that, there is another evidence-based model called the collaborative care model. And this model includes the primary care provider as the medical provider. And there is usually a behavioral health care manager who can be anything from an unlicensed provider to a nurse. They can also be a psychologist or behavioral health provider. And they're usually measurement-based outcomes for specific concerns. So this may be someone is being treated for depression and we're tracking depression throughout the clinic, or it could be a health behavior like diabetes management. And all patients that are enrolled in these services are part of a patient registry. And the behavioral health care manager works with a medical provider to monitor that registry and then reaches out to psychiatric consultants, typically psychiatrists. Therapists can also be a part of this model as consultants as well to manage the patient and try to maximize treatment. And then lastly, if you've worked in a VA setting or other settings, we have a team-based clinic here in our clinic. You may do team-based care where you, as a psychologist, are seeing a patient as a team with other healthcare providers. That can be anything from a physician or other primary care provider. It may be other individuals like pharmacy or OT or PT. It can be a huge team or a small team. And the idea is that you're seeing the patient at the same time in one clinic visit and able to provide recommendations across the care team. So when we're thinking about education, you may be working in a wide variety of these models with integrated care. You may be more co-located and have scheduled visits that are somewhat part of the care team, but you're not as daily integrated into that team. And so it can matter how you decide to educate your providers depending on what model you're using. But no matter where you are in education right now, whether you are teaching pre-K and have nothing to do with psychology, or you're going all the way up to medical school education, if you're in an institution of greater higher education, the main model to educate is competency-based education. This is a model that is getting more and more traction in medicine as well. In fact, we're all called as medical providers to now be providing competency-based medical education to our medical students and medical residents. And that's where a lot of my time is spent actually training those specialties while also training psychology learners as well. This model was originated back in the 70s, and the focus was on individualized learning to improve knowledge, skills, and abilities of learners. The idea that we have to really understand what a learner has to achieve to be able to become confident. So where do we want to see them long term, and then how do we get them there by really helping them learn a specific skill set, gaining the knowledge that they need and their abilities to utilize that knowledge and those skills. In addition to that, down the road, attitudes and behaviors came on board as well. So most of us who are educators are looking at things like professionalism in our learners and understanding their ability to self-reflect and things like that, but that wasn't initially part of the model. And this graphic that I have on this side really highlights competency-based education. The idea that you're focused on something, an end game, an endpoint that you want a learner to achieve or your care team to achieve. You have to decide and go backwards to identify what are those abilities, knowledge, and skills that they must have along the way. And then you have to focus on how is that individual or that team going to get there to that outcome. And this is in contrast to just saying, I'm going to have a learner here with me for a year, or I'm going to have a learner in graduate education or medical school for a certain amount of years. And just because they're here for that amount of years, we believe they're going to be competent to leave. It's saying, well, years should not be the determination. We should be having very specific objectives for how they're going to matriculate through our programs. And historically in psychology, this has been more of the case. You know, we all have been on different tracks and graduated in different years, but that was often really related, at least in my experience, to research and dissertation and not necessarily as much to that competency development, whereas in medicine, it's been very focused on the years of education. And so they're right now trying to go backwards to better understand how do we help learners be competent in each step of that medical education. So in my world, I really think of competencies when we're thinking about being an educator as very similar and akin to values work and things like acceptance and commitment therapy. This idea that it's an aspirational goal, but we actually have to work our whole lives to get there. So I may be competent in treating sleep disorders today, but in 2 years, a new treatment may come out that requires me to continue to work on my competence to be able to improve that, to stay abreast with the latest evidence and the latest changes in the field. And so it's something that I will never fully really get to or acquire. And the same goes for our learners, whether they are in their training or they're part of our team and licensed providers, is that we're always working to try to modify and improve our competence over time. And so the goal of competency-based education, as we're thinking about this within our care teams and with any of our learners, is that we are becoming ourselves and our learners master adaptive learners. I think about this similar to a superhero. You see the capes and the medical providers below. I don't know how many of you have watched all of the Marvel movies that have been out over the last couple of years, but the superhero comes into the game with a lot of skills and knowledge and abilities already, or they wouldn't be a superhero. But we spend our 2 to 3 hours of watching these movies, and we see that they need some coaching to be able to actually tackle the evil villains, and they often are hitting roadblocks to that. And so that's very similar in our role as an educator, is that we are here to be a coach to our learners, and that involves having to really look at them individually and adjust and plan accordingly to help them meet whatever objective we define as leading to competence in a certain area. And just a reminder for us all that we are just as much in the process as psychology educators as those that we are training or the learners that we have. I cannot tell you the number of times I have started an educational initiative and I think I know what I'm doing. I think I know where the learner needs to get to, but I don't have all the data actually that I thought I had. And I realize there's something I don't know. Or the same with a patient. I think I know what treatment we're headed down, and then I realized there was a whole slew of factors of things that I hadn't considered or that come up. And so the first step in being able to be an educator is to be able to have our own reflective processes and humility in this process to be a master adaptive learner along with those that we're trying to train. And so, as an educator, when we're thinking about how do we actually grow competence within our integrated primary care teams or with any learners that we may have across any discipline, there are multiple steps that we really have to think about to really make sure we're improving competence. And so the first step is we have to know what the competencies are that we're trying to get our learners to. And these can be really broad in terms of integrated primary care team-based competence, and then they can get more specific depending on the specialty that you are trying to educate. And this is something that I have had to learn over time, or what are the different competencies for the different members of my care team? Anything from the front desk staff to the medical learners, to the psychology learners, to other team members. And then not only do you have to know the competencies, but you also then have to actually have a plan of how you're going to get them to where you want them to be. So what is that outcome that you're trying to achieve? And then how do you actually set up the learning opportunities to get them to that outcome? And then you have to actually continue to evaluate that outcome to make sure that they get there. And then ultimately, our aspirational goal is that through that whole process, we have created in them and maintained and developed in us this desire for continued lifelong competence development. So we're going to talk through each of these areas and what that looks like in integrated primary care. So the first step is we have to understand what those competencies even are. And for those of you that may not be familiar, SAMHSA and HRSA got together several years ago with some organizations and came up with a core competency set for integrated behavioral health care teams. And in this set, the main areas of competence are things like team-based work and communication, and then you have your whole set of assessment and intervention competencies and care coordination. They included cultural competence and looking at the broader system. And then I really appreciate, especially with this competency set, this idea of informatics. They acknowledge that technology and data is something that we need to be more knowledgeable about in primary care. We love it and we hate it, and we're often saying that in the same sentence in our clinical care. And so they've included that in a competence. So when we're looking about our broad teams, let's say we need to improve crisis procedures across our team. We may need to be looking at the different areas that our team members touch that crisis situation and how we're going to get there as a team. In addition to that, most of us are working within care teams where there are specific disciplines within those teams, whether it's psychology, medicine, pharmacy, social work, and there are very specific competencies for those areas as well. And we're going to review a couple here today. So McDaniel and her team worked really hard with the APA to develop psychologist competencies in primary care. And those are listed here for you to review. In addition to that, Larkin put out a paper as well talking about psychology trainees. So those in the pre-doctoral to internship to postdoctoral work, what are the competencies that are needed there? And then very recently, Dr. Ogbide and Bales put together some thoughts on supervision competencies within primary care. So I'd encourage you to go to those resources. These are the competencies for psychologists that McDaniel and her team put out. So in looking at these, we're really talking about understanding the science, understanding systems, that professionalism, those attitudes, relationships and teamwork. How do we actually use the evidence for intervention and consultation? And then I've highlighted, they actually put a call out for us to be competent as educators and supervisors in our integrated primary care settings. In addition to that, medicine has its own set of competencies as well. For those of you that may not be as familiar, the Accreditation Council for Graduate Medical Education across all medical specialties. So even if you're not working in an integrated primary care setting, but you're in another health psychology setting, these competencies go broadly across those specialties that you may work with. And these involve areas such as patient care, medical knowledge, and then they have their own systems-based competencies and self-reflection competencies, both for their own personal growth and making sure they understand their ethics and things of that nature. And then they also have interpersonal and communication skills, pulling in that team-based approach that they need to be able to work within medical teams. And in addition to that, Martin and his team put together a Delphi study to look at what medical residents in particular need if they are being trained within integrated behavioral health teams. And so as you can see, these competencies are quite similar to the others that we have just reviewed. They involve communication and teamwork. They involve that care, coordination, intervention, assessment. They include the cultural competence and then also the professionalism and self-reflective values as well. So I'm going to give you a moment. I know this screen there's a lot of small words on here, but when we think about therapy, we often think of the common factors approach and this idea that we have all these wonderful evidence-based treatments, but if we don't have the common factors on board, we may not be very successful with our patients. And so I just want you to see the commonalities across these competencies, that really when we're looking at integrated behavioral health care teams, we are all on the same mission. To improve competence really in the same areas. So whether you're working just with psychology learners or you are working with medical providers or other care specialties, we're after the same thing. We're after team-based care and communication. We're trying to shore up our intervention and assessment and care coordination strategies. We need to be taking a cultural lens when we do that. And then we have to consider the systems that are at play within our settings and really think about the professionalism. How much are we aware of what's going on within ourselves and how does that influence those around us as well as our ethics? And so it's really nice to see that we're all on the same page. And so we need to think about this when we're considering our educational interventions. So after you understand the competencies, so step one, you got to know what they are. Step two, if they're specific to the disciplines you're trying to tackle, you really want to be able to identify what it is you want to achieve with whatever you decide to do, whether that's a didactic or it's a clinical skills training, whatever the situation is. But then you have to actually decide the what of your intervention. I describe it sometimes as planning a trip to Disney World for anyone that's ever tried to do that. There are multiple factors at play, and you often have to think way ahead and try to troubleshoot what the problems are going to be ahead of time to make an appropriate plan. And so some things to think about as we're wanting to build these master adaptive learners that are self-aware and can identify their own needs and learning objectives in this coaching model, we really need to understand what the problem is. So I'll give an example in my clinic. Since I work with a lot of medical residents, we've built these wonderful integrated behavioral health services, but I was recently told by some residents that they never actually have engaged in safety planning themselves for crisis because they always call our integrated behavioral health team, which is excellent. That means our integrated behavioral health team is doing a wonderful job. However, most of my residents are going to rural and underserved places where they will not have an integrated behavioral health team. And so I need them to have some competence in actually doing that themselves. And so this is a problem for me. And I've had to think about, okay, So what do I need to do to change in their training to make sure that they can demonstrate the competence as well as utilizing our care team? And so I have to ask myself, okay, this is an area of competence related specifically to patient care and intervention for them. And I've had to think a lot about what strategies need to be in place for us to modify this within our clinical setting. What and who needs to be involved. I've had to do some needs assessment work with my colleagues, both in behavioral health and in medicine, to try to figure out, okay, is this something they really need to know? And if so, how do we go about doing that? They've had multiple didactics on the topic, so it's not didactics. I know we've got to think about real live direct intervention. And then how will I know that they're successful? How do I know that they can do a safety plan successfully individually? And then how do I encourage them to continue to use our integrated behavioral health services? So when we think about this, we want to think about this curricular design. I liken it somewhat to the trans-theoretical model of change. I wish they had a little circular loop in the middle to say the more you do this, the better you get, and the more likely you can modify educational objectives. This may look kind of small to you, but these are the same steps that we just went through in a more circular pattern. So really identifying what the problem is that you're trying to solve in your clinical space. And this could be clinically, this could be the way a team is functioning. It can look a lot of different ways in this integrated primary care space, and it can be targeting a lot of different professionals. Then you really need to know who needs to be involved in the change. So is it just something within your behavioral health providers, or is this like a team clinic-wide situation where you need to get multiple people on board? And then you have to say, okay, what do we want to achieve? Who needs to be involved? And then how are we going to go about doing that change? What are we going to need to teach? Is this a didactic? Is this knowledge that needs to occur? Or is it some kind of direct skills that we need to develop direct observations to be able to monitor their skill development? And then we have to decide, how do we even know that they're successful in that? And then it's circular, because you're likely going to continue to modify throughout your time as an educator. So the things that I did 8 years ago in this setting are very different than the things I'm doing currently, because I'm constantly having to go through this process and make modifications based on the evaluation and feedback that I get. And that is everything from uh, adding a new treatment to our care team, to trying to train a specific specialty in a certain clinical skill, to trying to make sure that the front desk checks in our patients and gives the right assessments on up front. It can, when we're in primary care, there are a lot of different ways that you're having to educate your team. So once you have figured out the what's the problem and how you're going to plan on going about solving it, you have to figure out how you're going to actually evaluate the success of that educational initiative. And so traditionally and typically, a lot of times when we've been learning knowledge, that's like a test of some sort, some kind of survey to elicit some kind of understanding of the knowledge or content. But the reality for us as educators in the primary care space is so much of our evaluation ends up being actual direct observation of a clinical skill. And so how do you go about doing that in a busy clinic? How do you set up non-clinical observational opportunities that are not in vivo, but they may be planned for that direct observation? But you have to think really strategically that it's usually not just a didactic that you give that leads someone to gain the skills necessary to change their clinical practice. So how do you go about building that out? And then as you do that, because it's usually an iterative process, observing someone one time usually doesn't lead to lasting change. How do you provide feedback, and how do you provide that well? How do you engage the learner in that feedback process? So thinking about their own self-reflection, because to be a master adaptive learner, we have to be empowering our learners to becoming their own barometer of feedback. So what have they been doing well that they can identify, and what are the areas of growth that they need to grow in, and they need to be able to demonstrate and verbalize that to us. And as educators, we need to be prepared to actually verbalize that to them. And when those are misaligned, how do we have those conversations with our learners? I often joke that I need a sign that says I'm giving feedback now, because the feedback that I often receive as an educator is I didn't know I was getting feedback, or I wish I had gotten this feedback a long time ago and this feedback is too delayed. And so I just want to encourage everyone on this call today, if you have learners or you are providing education in any way, the sooner the better with feedback, and the more clear and direct with your Oreo sandwich approach, with the good, the bad, and then the good again, can be really important when you're have learners in your setting. We also, I don't want to speak for you. I enjoy receiving feedback too. It can be hard to receive, but it's important for me to also, as I'm an educator, build in a mechanism to be able to receive feedback as an educator, to then be able to modify my educational initiatives for my learners as well. And then lastly, really considering how you're building plans for your learners. So when you create an educational initiative, how does that learner know that they are engaged in that initiative, and how do they know what they actually have to achieve? So what is their individualized learning plan, whether this is in clinical supervision and you're starting out, whether you do it in semester or year, what individualized plan do you have for your learner? Whether you have a broad strokes with medical residents, or it's your team, you're doing more of a QI initiative where you're trying to understand some process. It can be really helpful to understand what are those individual and team-based, very specific learning objectives and goals that we're starting at, so that we can evaluate how we actually ended. Like, were we successful? And so I would encourage, if you haven't done this, to really think about that when you are initiating any kind of learning opportunity in your clinical space. And lastly, the goal for us as master adaptive learners using competency-based education is, how are we empowering our learners for this lifelong opportunity to grow? I think about it often as a dialectic. If you are familiar with dialectical behavioral therapy and DBT, the whole point of that with a patient is trying to help them understand that life is lived in the middle, in the gray zones, and that we often can think on extremes. And the same thing happens in our learning process. I can think I'm a wonderful psychologist or I'm a horrible psychologist, and I can go to those extremes really quickly depending on the feedback or the patient interaction I may have. And most of us as learners, when we're in the learner setting, and even as supervisors, can come out feeling that way based on the feedback we receive. But to be a master adaptive learner, we want to keep our learners in the middle, for them to understand that they are always going to be learning, no matter who they are, where they get as a psychologist, in whatever powerful position they may have one day. The goal is that they will continue to feel like they need to learn. And yet, there are small victories that we can show and demonstrate that they are growing in that competence, and that there are endpoints to that where they can get a gold star that says, hey, I learned this, I'm doing this. I accomplished this objective, and I am competent in this area. And so it's always a mixture of both, and helping our learners understand that and believe in that. And part of that is demonstrating that ourselves, and our own self-reflection in the learning process, that we are too are always learners on the journey with them. So I want to provide an example of what this may look like if you are an educator working as a psychologist within an integrated setting in any way. And so for years, we have been trying to improve our motivational interviewing training for our family medicine residents, in part because we recognize that they are often the drivers of health behavior change, along with our integrated behavioral health teams. And so when we started, we were doing a lot of didactic training, some experiential work, and we were really trying to target some broader competencies with them. And it is often that you're trying to tackle multiple competencies with one educational initiative. For us, we wanted them to improve their patient care for health behavior change areas. We also knew that they weren't coming in to residency with a lot of medical knowledge. They may have gotten some brief training in medical school. Some have more than others, but the knowledge was not leading them to really change their patient care. Motivational interviewing in and of itself is often utilized communication skills, and so we believed it would bolster those. And we also, as part of the process, wanted their professionalism to improve, for them to have some self-awareness of their strengths and areas of growth with motivational interviewing, because often when we ask our residents, they say they're good at it. And so we have to find a way to be able to demonstrate that that may be true for some, but it may not be true for everyone. So we were thinking about this as we started to develop our educational initiatives. And then we also wanted to look very specifically about the residents' role in our integrated behavioral health efforts. And so in the last couple of years, for those of you that may not be familiar, in at least family medicine resident education, residents are required to have some kind of experience in motivational interviewing. And we started this initiative before that was even the case. And then in this integrated competency framework from Martin, we really were tackling that intervention assessment portion of those competencies. We wanted them to be able to feel competent to go in the room in their patient encounters and be able to utilize motivational interviewing to address behavior change. And so we had to think really hard about what our plan was for their growth and development. And we've had to modify this over time. Like I said, it's a lifelong, it can be a lifelong or career-long process to get us to where we want to be. And so we had to really think about, what is our problem? Our problem was we had done didactic training for several years with an experiential component. Like, they're in didactics and they role play, and that's very typical with motivational interviewing training. But what we were getting were reports that they weren't actually doing that within their clinical spaces, and they weren't doing that effectively. And so we had to ask, okay, what was the issue that was getting in the way of that? And then what do we need to change? Who do we need to get involved to change this initiative? And how would we know that it was successful? And so our problem, like I said, was this continuous report that they wanted more training despite having training. And we learned that the time we were spending, so we used to give them 20 to 30 minutes to have a patient encounter. And when you only have 5 minutes in medicine, that was way too much. So they were taking that and then they weren't applying that to their actual clinical skills in their clinical spaces, because they were saying, look, I don't have 20 minutes to talk about health behavior change with my patient. And so we realized that our training itself was not effective in actually leading to their care delivery. And so we had to look at the intervention that we were wanting them to provide, and had to realize it is very different than what a traditional psychologist is going to provide in this behavioral health, health education space. And so we utilize this model to look at, how are we going to actually go about modifying our training and our clinical experiences to help them grow in these skills. And I chose this today because Rolnick, Miller, and Butler, they have also stated that didactic training alone usually does not lead to skill gains. And so I just want to put that out there. It's really easy to create a didactic. Well, it's not always easy to create a didactic, but it's often the way that we are trying to train our learners. And the reality is, often we need to be thinking about clinical skill development that we need to put in place for them. And they agree with this. There's also some research coming out of the Integrated Behavioral Health Institute out in East Tennessee, where they've been doing some research also stating this, that it's really in these clinical spaces that we need to think about, how do we train to clinical skill development, not just didactic training for our learners. And so we took this and we said, okay, we need to talk with our other primary care providers, as well as our residents, of how do we actually train someone to do motivational interviewing within 5 minutes, and how do we demonstrate that there's any kind of proficiency in that. And so over time, we have had to modify and develop our educational initiative. And one of the things we realized early on is that our residents had to believe that it was important to know motivational interviewing because of the way that it was going to influence their practice. So we've added a pre-training podcast where they have to actually listen to a doctor talk about the ways in which motivational interviewing has moved them out of burnout. Because it has changed their lens and perspective on the fact that they can't change their patient. So 5 minutes talking to their patient, the patient has to be the change agent, with them coming alongside as that guide. We had to modify our didactic curriculum to be more specified just on individualized residents, with a lot of provider a demonstration and then having them be the provider over and over and over again with direct observation of their skills and direct and immediate feedback on the ways they can improve. Then they've had to have a time where they can go back and practice that independently and then come back and re-demonstrate their skills in the areas that they have learned. And this is much more involved as an educator than I originally thought education was, of psychology learners or medical residents, and really thinking through where do I want them to be able to be. And where I wanted these residents to be and want them to be is to be able to go into their independent practice and demonstrate this and desire to utilize this skill for behavior change. And so we had to really think about, how do we know that they're going to be successful in their competence? We have to be able to directly observe it. And so we've had to build in very specific places to be able to observe what they're doing in their clinical skills. And then we have to think about, how do we maintain this? And also, how do we evaluate whether it's still working? You know, it may be working for this set of residents today, but 5-10 years from now, it's a different set of learners with different backgrounds, different life experiences. The world may look different. Their learning styles may change. And so we have to continuously think about how we improve that. And so we also track longitudinal data. So we're looking at, how do they report that their knowledge has improved, both from that direct observation perspective to also having survey items on surveys that we ask them, how is that working? And then how are they actually implementing this in their current and future practices? And so I'd encourage you, as you're creating any kind of educational initiative with whatever learner or team you have, how do you know that what you're doing is working? And how do you demonstrate that the individuals that you're working with are actually competent to do whatever it is you say you want them to be able to do? And then to end today, just the reminder that we are on this journey. I've said it multiple times today, to develop competent lifelong learners. And so, how we do that best is by always helping them with our own self reflection as educators, that we are all on this journey of education. There are highs and lows, there are hills and valleys, but we are, hopefully, you like myself, are never reaching the destination fully, but we are always wanting to empower our learners that we are learning. We are master adaptive learners wanting to improve competency in ourselves. And we also are holding our learners to that standard. Again, whether that is your actual learners who are non-licensed or in their training, or it is part of your care team to come with a reflective lens to encourage them on the journey to becoming improved team members and improving interprofessional collaboration for integrated behavioral health. So that is the end of my presentation. I'm happy to try to answer any questions that anyone may have about education in this integrated primary care space.
Thanks, Meredith, for your presentation. This was awesome. I was wondering if you could share that podcast that you talked about
Sure.
on burnout. I would love to take a listen and then see if it would be helpful for our residents as well.
Yes, I am happy to. I don't know if I can get out of my screen right now, and but I will send it. Would everyone like that? I'm happy to send it to Steph to distribute to everyone if that would be helpful.
Looks like it's popular, Meredith, so that would be great.
Okay, perfect.
We have a question from the chat. Could you elaborate more on the collaborative care model, please?
Sure. I can go back. Let me see if I can go back to that slide for you so I can show you. Let's see here. Almost there. All right, so here's the collaborative care model. So the idea of this model is it is usually a system-based intervention. So within a clinic or a healthcare system says, hey, we want to use this collaborative care model. And the idea is that we're going to target a specific diagnosis or area of care. It was, I believe, originally utilized with depression. And so you create your own way of monitoring outcomes within your system. So let's say it's depression, maybe it's you give the PHQ-9 to all adults when they come in, either annually or every visit, or in a specific category that you may identify that they need to get that measure. And then based on that PHQ score, that primary care provider who's administering that at their primary care visit can offer to enroll the patient into their collaborative care program within their clinic or their system. And usually there's a behavioral health care manager that's either on site or part of the system that comes on board at that point if the patient agrees. They can meet them anywhere from same day, like the primary care behavioral health model, or they may be via phone. When I worked in the VA, it was a nurse that was managing multiple clinics. And then that care manager works to try to help the medical provider maintain treatment gains or initiate treatment gains for that patient. So maybe they call and do a follow-up to check in and re-administer the PHQ. Maybe the medical provider started an SSRI or something like that, and they're following up on side effects. They can also do solution-focused or brief intervention in some models. In some models, that behavioral health care manager is a psychologist and is doing actually evidence-based psychotherapy as part of that role. And then all patients that are part of that collaborative care initiative are entered into a registry so that that behavioral health care manager can monitor their progress with those measurement-based outcomes, those PHQ scores, or some other measure. And then when needed, they can utilize a psychiatric consult who is usually on board as part of this model as well to provide influences on medication. Maybe they may do a brief assessment with a patient that has severe treatment-resistant depression and send recommendations back to the medical provider. But oftentimes that consultant is also going back to the care manager, and they're working more closely together, reviewing that registry with them on a semi-regular basis to identify patients that may need to bump up the intensity of their care, or those that are doing really well and can graduate from that care. And so I'm not sure if that answers your question, but I'm happy to try to answer any other questions. And the AIMS Center is a wonderful resource that is on this slide. If you want any more information, they have a ton of resources on this model of care.
All right, thank you. A few more questions. So one is, could you share your references? So maybe when you send out the podcast, if you choose to do so.
Sure, I am happy to, and I have them attached to this PowerPoint, so I'm not sure if the PowerPoint goes out to you, but I'm happy to send all of that.
So the PowerPoint will be on the website. So
Perfect.
excellent. How do you usually provide feedback to learners? Which way have you found to be most productive?
I have found it most productive to provide both verbal and written feedback. So anytime, and in multiple settings. So if we are in the middle, like we have a team-based clinic and I provide verbal feedback, I always ask the learner first, what do you think you've done well? And are there any areas that you think you could have done differently or want to grow in based on your encounter with a patient? If it's a patient encounter, if it's an educational opportunity, the same thing. We just have gone through this training opportunity. Tell me what you did well when we were, role playing or something. What did you want to grow in? And then I provide this same back to them. So I validate whatever they, demonstrated or reported back to me, and then I provide my own feedback of what I did well and what I thought they did well, and then what they could improve on. And then we try to make plans to improve on that together. And then I highly recommend you also put that in writing when you can. So for our residents, we have direct observations that are written. So we provide the verbal observation and then we put that into their evaluation metrics. And then also they have end of rotation evaluations that are written because oftentimes we hear things in the moment that we often don't take with us. And some of us are better at hearing positive things and some of us are better at hearing negative things. And so it can be helpful to have it written down. Let me know if you need more explanation.
Okay, one more from the chat. Can you discuss how you frame this training for students going to more rural areas? Thinking about aspects of how to handle more chronic behavioral health conditions in areas with limited traditional outpatient options for changing levels of care.
Yeah, that's a great question. I think about it every day. So we try to train our residents in both routes. So thinking about if there isn't a behavioral health provider, within 100 miles, how can they actually demonstrate competence? And this is, outside of this talk, though, we have our own mechanisms for demonstrating competence in a full psychiatric interview and psychopharmacology, in addition to helping encourage them to utilize integrated behavioral care models and demonstrate competence in utilizing those. But the reality is having those frank conversations that you didn't go into medical school and you didn't choose family medicine because you wanted to be a psychiatrist, or you would have chosen psychiatry. However, presenting the data that primary care is the main place in which behavioral health is being cared for in this country. And even if we multiply ourselves like 3 or 4 times, we will not even be able to begin to meet the demand that is needed in these rural and underserved places. And so, unfortunately or fortunately, they get the opportunity to meet people where they're at, and that takes different skill sets. And so we're here to try to help them grow those, both the brief skill set for those that need that, and also for the more in-depth over the course of continuity of care, just like they want to know the course of diabetes or hypertension, that if they're going to really have a relationship with their patient, it's important that they know the course of their behavioral health trajectories as well. And so that's kind of the conversations that we have very bluntly and directly with our residents, given that they want to go to these rural settings and they will be the de facto behavioral health support. And then we also recommend that they work really hard to understand what those referrals are within their community and who they're going to collaborate with. Even things like understanding their ER support, understanding their local mental health authority support, understanding those that are hundreds of miles away, how are they going to consult and utilize those services effectively wherever they go. And we always say, you also want to get to know your therapist in your area, or your psychologist, your behavioral health providers, and understand what they do, because we're training them to look for certain ways of treatment intervention, and we want to encourage them to look for those in the communities they're headed to.
That is all from the chat at the moment. But you're also welcome to speak up if you'd like.
Oh, sorry.
All right, if there's no other questions, just want to thank you so much, Dr. Williamson.
Yeah, thank you for having me, and thank you all for spending your lunch with me. I know days are busy, so I appreciate you all coming to this presentation, and I'm happy to answer any questions. My email's at the end of the presentation. I don't know if I can get there, but I am happy to try to help provide any resources or anything that I can along the way, and the references are there too when they're uploaded. So thank you so much.
And as a reminder, this recording and the PowerPoint will be on the Society's website under resources, along with several other wonderful presentations. And just, again, thank you for attending the webinar today. So remember, if you would like the CE credit for attending, please respond promptly to the evaluation link, and that'll be sent out via the email that you signed up for this presentation with shortly. We'll leave the evaluation period open until Wednesday, October 16th, 2024. And the CE certificates will be sent via email within 5 to 10 business days after the evaluation period closes. And remember, even if you aren't seeking CE credit, we still value your evaluation. And feel free to email us at admin@societyforhealthpsychology.org if you have any questions. And again, thank you to our speaker for this amazing presentation, and thank you to our audience. Have a good day.